Hello everyone, we will be starting in a minute. We are just waiting for other participants to join the YouTube live for now. Okay, so good evening everyone. On behalf of AMSA India, we extend our warm welcome to all of you in today's event. We hope this event will be beneficial to each one of you. First of all, I would like to give a brief review about the timeline of the event. We have got a short webinar for you on the concepts and facts of type 2 diabetes. The webinar presentation has been reviewed by Dr. Shyam Kishore himself, and the speakers will be Aditya Arora and Tanishka Kochar. Progressing this, we will have a short quiz of 15 minutes. After all of you have completed the quiz, Dr. Shyam Kishore sir will enlighten us more on the topic, updates and new advancements in the field of diabetes. We will address all your questions through the chat box without interrupting the speaker during the Q&A session. The top 48 participants of the quiz will then move on to the next phase, that is the group discussion. The rules of group discussion will be explained later before the commencement of the phase 2. Moving forth, we would like everyone to consider some norms of the session. Please keep yourself muted at all times unless you are asked to unmute. This is just to ensure the smooth flow of the event. If you guys have any queries, you can text on the Zoom chat to the host or any of the co-hosts privately. Without further delay, we'll commencing the webinar. I would now like to invite Aditi Arora to take over.
Thank you, Devesh. Good evening, everyone. I hope I'm completely audible. I'm Aditi
Yes.
Arora, and I, along with Tanishka Kocher, will be presenting the webinar. We will be talking all about the disease diabetes mellitus type 2. So let's get started. Nandini, please start sharing the screen. Thank you so much. So, diabetes mellitus type 2, control the silent killer. Type 2 diabetes is a disease which is taking a strong ground with immense speed. And within the blink of an eye, we will be witnessing an epidemic. And not soon later, we will reach a stage where most of the population in the world will be in the grips of type 2 diabetes. Next, please. According to WHO, diabetes is a chronic metabolic disease characterized by elevated levels of blood glucose or blood sugar, which leads over time to serious damage to the heart, the blood vessels, eyes, kidneys. Amongst both, the most common is type 2 diabetes, which was formerly called as non-insulin dependent or adult onset. Type 2 diabetes results from the body's ineffective use of insulin. Next. Now, type 2 diabetes mellitus. This type of diabetes is largely the result of excessive body weight and physical inactivity, which occurs when the body becomes resistant to insulin. Symptoms may be similar to those of type 1 diabetes, but are often less marked in DM type 2. As a result, this disease may be diagnosed several years after the onset and only after when complications have already arisen. Until recently, this type of diabetes was seen only in adults, and therefore it was called adult onset diabetes, and it is now also occurring increasingly and frequently in children. Next, please. Now, let's move on to epidemiological factors or the risk factors of diabetes mellitus type 2. I would urge you all to pay extra attention in this section as it will help you brainstorm in the group discussion. Yes, so let's continue. Next, please. According to the triangle of epidemiology, we have three main factors to be discussed. That is agent factors, host factors, and environmental risk factors. But not going too deep into it, we have divided the factors for you into non-modifiable and the modifiable risk factors for DM type 2. Now, talking about the non-modifiable risk factors for DM type 2. Now, these are family history or of diabetes or genetic history, race or ethnicity, age and sex, and gestational diabetes. Firstly, discussing family history of diabetes or genetic history. Now, the genetic history of diabetes is undisputed. Like there are twin studies which have shown that identical twins who develop diabetes type 2 have a concordance of approximately 90%. And this demonstrates that type 2 diabetes has a very strong genetic correlation. Now, moving forth to race and ethnicity. Race and ethnicity alters the risk of diabetes. Plenty of past researches on race, ethnicity, and diabetes have been done. And some studies have confirmed that there is a greater risk for Blacks, Asians, and Hispanics, according to a study. Now, the next factor is age and sex. In some studies, like example, take UK. Now, the male and the female ratio is almost equal, while in some like the Southeast Asian countries, we have excess of male diabetes, which has been observed recently. Although diabetes occurs at any age, surveys have indicated that prevalence rises steeply with age. Type 2 diabetes mellitus usually comes into light in the middle years. Then the last non-modifiable factor, which is the history of gestational diabetes. Now, offsprings of diabetic pregnancies including gestational diabetes, tend to develop obesity in childhood and are at high risk of developing type 2 at an early age. Next, please. Moving forth to the modifiable risk factors of DM type 2. Now, there are several various risk factors that we ourselves can alter, and these are sedentary lifestyles, high body weight or obesity, high fat and cholesterol levels, stress, excessive intake of alcohol, smoking, and high blood pressure. Let's discuss each factor briefly, as these factors are the main points for which you will be discussing upon in the group discussion. Now, the first one being sedentary lifestyle. With the advancement in technology or extended office hours, desk jobs, and of course, like not in the lockdown, but I'm sure before that and after the college starts, we'll all be continuously studying and sitting in the libraries or reading rooms. So I'm sure you all will relate to this. So our lives have become sedentary. Even though we have mental activity going on, we are physically inactive. Sedentary lifestyle appears to be an important risk factor for the development of type 2 diabetes. Lack of exercise alters the interaction between insulin and its receptors and subsequently leads to type 2 diabetes. The next factor is high body weight or obesity. Obesity, particularly central adiposity, which means accumulation of fat in the lower torso around the abdominal area. It has been accepted as a risk factor for type 2 diabetes mellitus. Now, let me ask you a simple question, guys. You can type in the chat box if you know the answer. So the question is, why does obesity lead to DM type 2? If any one of you know the answer, you can just type in the chat box. Yes, so the answer to this is, well, obesity causes increased levels of fatty acids and inflammation, leading to insulin resistance, which then further leads to type 2 diabetes mellitus. Now, the next factor being high fat and high cholesterol levels. As mentioned earlier, obesity is accumulation of fat, and more fat and more cholesterol is then a risk factor for DM type 2. Moving on to the next, we have stress. Now, not only mental stress, but also stress due to surgeries, traumas, like the internal and the external stress, both types of stress may bring out the disease. Stress can be a major barrier to even in the effective glucose control of the body. Stress hormones in your body may directly affect glucose levels. Then the next factor we have is the excessive intake of alcohol. Now, this can increase the risk of diabetes by damaging the pancreas, the liver, and also by promoting obesity. Then smoking. Smoking. The smokers are 30 to 40% more likely to develop type 2 diabetes than the non-smokers. So no matter what type of diabetes you have, smoking makes your diabetes harder to control. If you have diabetes and you smoke, you are likely to have a serious health problems from diabetes. Now, the last modifiable factor for DM type 2 is high blood pressure, also known as hypertension. It is very common in people with diabetes. In fact, the two conditions, often go hand in hand because they can both result from the same lifestyle factors. Next slide, please. Yes. Now the symptoms. Now the most of the symptoms of type 1 and type 2 are very common, that they're similar to each other. The symptoms of diabetes type 2, they develop very slowly, and most of the times the disease has an asymptomatic presentation. That means the disease, the patient would not even show any symptom and would still have DM type 2. Now, the patients with type 2 diabetes mellitus are always very thirsty. Medically speaking, the term is polydipsia. And why exactly this happens, why polydipsia happens in patients with DM type 2, I'll be explaining very soon. Now, the next symptom is polyuria, that is excessive urine output. Now, the patients with type 2 are very lethargic, always lethargic. They look and feel as if they are very sick. These two conditions, they're termed as fatigue and malaise. So a patient with type 2 diabetes mellitus would always show a symptom as fatigue and malaise. Now, the next symptoms are blurred vision, affecting the eye, of course, diabetes affects the eye. Then we have slow healing of wounds. We have, and the last one being unintended weight loss. Now, next slide, please. Moving forward, let's discuss the clinical features and the consequences of diabetes mellitus type 2. Next slide, please. Now, the consequences of type 2 diabetes, these are hyperglycemia, protein catabolism, and ketosis. Now here, hyperglycemia and protein catabolism are the main consequences, with ketosis as a consequence, which is very, very rare. Next slide, please. Yeah. Let us discuss hyperglycemia in detail, as hyperglycemia is one of the major consequences of diabetes mellitus type 2. Now, hyperglycemia, hyper meaning more and glycemia meaning sugar. So it means excess blood sugar. Now, excess, but how much? How are we going to evaluate the excess amount? So if it's more than 180 to 200 milligram per deciliter, it is considered hyperglycemia. Now, normally what your kidneys would do, like when your kidneys create urine, they would reabsorb all the sugar, and it would direct it back into the bloodstream. But in diabetes, there is excess levels of sugar in the blood. So what now in this condition it will do is, the blood sugar will now be present in the urine. And this condition is known as glycosuria. Now excess glucose is ending up in the urine. Now what this will do is, it will pull more water into the urine. Okay, this leading to more output of urine, known as polyuria. Subsequently, there is also loss of electrolytes and body weight. Due to polyuria, the water level in the body would decrease. This would definitely make the person thirsty. And as I mentioned earlier, it is known as polydipsia. Now, polyphagia is also presented. Now, I'm sure you've understood why polydipsia occurs. For polyphagia is also presented. Okay. Now, high levels of blood glucose. High levels of blood glucose will lead to hyperosmolality, which will further lead to CNS dehydration. Now, this is a very, very severe stage, as this can lead to coma. Now, hyperglycemia, it has major effects, as mentioned, I've been mentioning, on the kidney, the eyes, and the CNS. Thus, the other complications would be diabetic nephropathy, retinopathy, and neuropathy. Next slide, please. Now, type 2 diabetes accounts for 85 to 95% of all diabetes. It has a latent asymptomatic period of subclinical stages, which often remains undiagnosed for several years. Now, beta cell dysfunction occurs due to hyperglycemia. Now, let me explain you in brief as to how this happens. Now, type 2 diabetes occurs when your body cells resist the normal effect of insulin, which is to drive glucose from the blood into the cells. Now, this condition is called as insulin resistance. As a result, glucose starts to build up in the blood. In people with insulin resistance, the pancreas sees the blood glucose level rising continuously. The pancreas responds by making extra insulin to maintain a normal blood sugar. Now, over time, the body's insulin resistance will get worse. It gets worsened. And in response to this, the pancreas makes more and more insulin continuously. Finally, what happens is the pancreas gets exhausted, and it cannot keep up the demand for more and more insulin. As a result, the blood glucose level starts to rise. Next slide, please. Now, protein catabolism. Now, catabolism in simpler terms means breakdown. Now, insulin is an anabolic hormone, and in type 2 diabetes mellitus, what happens is its anabolic action is interrupted. This leads to excessive breakdown of proteins, known as proteolysis, and less protein synthesis. Now, our muscles are mostly made of proteins, and if there is excessive proteolysis, muscle mass is definitely going to decrease. Now, if you guys remember the symptoms, I mentioned fatigue over there, and I hope you now know why. Now, the next is negative nitrogen balance. Now, negative nitrogen balance occurs due to protein catabolism. Normally, an increase in the protein intake produces an increase in the nitrogen losses via higher amino acid oxidation. especially in the fed state. And then this leads to trends towards to the positivation of nitrogen balance. And similarly, a loss in protein would lead to negative nitrogen balance. Next slide, please. So thank you so much, guys. The further presentation will be now taken up by Tanishka Kocher. Tanishka, please take up the screen.
Thank you, Aditi. So now that all of you are well versed with the epidemiology and clinical features of diabetes mellitus type 2, let's look at some complications of the disease. So two broad complications that DM type 2 might lead to are microvascular and macrovascular disorders. Microvascular disorders are those which affect the small blood vessels, and macrovascular are those which affect the larger blood vessels, eventually leading to conditions such as myocardial infarction. Talking about the microvascular disorders first, we have first retinopathy. So in retinopathy, all of us know that diabetes patients suffer from eyesight problems. So the retina of diabetic patients gets affected, leading to blurring of vision. And if it furthers, it might also lead to complete blindness. Second is nephropathy. In nephropathy, blood vessels of kidney are affected. They get blocked and the blood does not get cleaned properly. Third is neuropathy. In neuropathy, some major nerves of the CNS dysfunction, leading to symptoms such as muscle weakness, pain, tingling sensation, and also numbness. Fourth one is foot problems. These are seen in both micro as well as macrovascular disorders. By foot problems, we mean that the patient would suffer from symptoms such as tingling or numbness. For example, if the patient is wearing a sock and there is a pebble in it, or if he has a foot blister, he might not even feel it at all. So now going on to the macrovascular disorders, the first one being cardiovascular problems. The main cardiovascular problems seen in diabetic patients are coronary arteriosclerosis and also heart attack. The second one is the cerebrovascular disorders, where the blood vessels of the brain might get blocked and result into a spasm. The last one is peripheral vascular diseases, wherein the blood vessels which supply blood to our extremities start narrowing. So, the diabetes mellitus type 2 is a disease which has a very, very strong genetic background, to an extent that there are more than 15 genes which play a role in its occurrence. Discussing some main ones with you would be, first is CAPN10, which leads to impairment of glucose transport. Then CAMK1D, which leads to impairment of beta cell dysfunction. And the CDC123 also does the same, impairing the beta cell dysfunction. Now let's discuss about the diagnosis of diabetes mellitus type 2. The most common and the most accurate diagnostic test for the diabetes type 2 is the glycated hemoglobin test, also known as the HbA1c test. As we know, a diabetic patient is in a hyperglycemic condition, so that extra glucose starts getting attached to various proteins. One of the proteins that it gets attached to is the globin protein of hemoglobin, resulting in glycated hemoglobin. So a measure of this glycated hemoglobin lets us know whether the patient is suffering from diabetes or not. The normal level of this test is 5.7%. A result between 5.7 and 6.4 would suggest pre-diabetes, and a result above 6.5% would suggest diabetes. Even though the HbA1c is the most accurate, it can't be done in all patients. For example, pregnant women and people with a hemoglobin variant, as it may interfere with the A1c test. So let's look at some other alternatives that we have here. The first in the yellow box is the random blood sugar test. As the name suggests, it's random. So we don't need to ask the patient to fast at all. The blood sample can be taken at any time. If it's greater than 200 milligrams per deciliter, then it's suggestive of diabetes. The second in the green box is the fasting blood sugar test. As the name suggests, we would have to ask the patient to fast. So the blood sample is taken after an overnight fast, and if it comes out to be greater than 126 milligrams per deciliter, it is suggestive of diabetes. The third one is the oral glucose tolerance test, commonly known as OGTT. This is not commonly done as it is a very cumbersome test, but it is done in pregnant women. So in this test, after an overnight fast, the patient is asked to drink a sugary liquid at the doctor's office, after which periodic blood samples are taken. Next slide. Yes. Now comes the big question. Why is diabetes mellitus type 2 likely to be the next pandemic? So to understand this, let's have a look at some statistics. Next slide, please. As we know that a huge amount of the world's population suffers from diabetes, and 90 to 95% of them have type 2. Diabetes is extremely common in adults, because of which more than 1 in every 10 adults has diabetes. Considering the country that we live in, India is the diabetic capital of the world. Global prevalence of diabetes is increasing at such a high rate that it is suggested that it may project to a number of 7,079 per 1 lakh by 2030. So now looking at the green box, the current prevalence of the disease is 6,059 cases per 1 lakh. Looking at the yellow box, WHO advocates that in 2017, approximately 462 million people were suffering from diabetes in the world, which accounts for 6.28% of the world's population. This not only included adults, but also people from the younger sections of the society. So please remember 6.28% of the world's population. Looking at the red box, over 1 million deaths every year occur due to diabetes. And this is exactly why it is likely to become a pandemic, because it is leading to so many deaths to an extent that it ranks ninth in the causes of mortality. Looking at the blue box, if we talk about the gender distribution, there is not much difference in males and females, but the disease definitely peaks at the age of 55 years. A statistical data collection done by the National Council of Biotechnological Information, NCBI, forecasted that the diabetic cases are rising at such a rate that we will end up having 7,079 cases per 1 lakh in 2030. And by the time we reach 2040, the number would become 7,862. This is also evident from this graph, where you can see that cases in each continent are starkly increasing. Until recent times, the prevalence of DM type 2 has been higher in adults, peaking at the age of 55. But let's look at some current trends. As you can see in the graph, the black line represents earlier times and the red line represents the current times. We can see that the red line is considerably higher in younger age groups. This is something that merits immediate attention. Most research-based studies suggest that most of the young people who get affected are suffering from obesity. Next slide. So we'd like to end by the quote that it's not the strongest of the species that survives, nor the most intelligent, but the one most responsive to change. And we should be the change we want to see in the world. That brings us to the end of our session. I hope we were able to brush up your knowledge about diabetes effectively. So now it's time for the quiz. Without further ado, let's move on to the quiz. We will be putting up the quiz link on the WhatsApp group. So I request all of you to remain active on your group right now. The quiz will consist of 15 questions and there will be a time limit of 15 minutes. Your time will start as soon as the link is posted on the WhatsApp group, and you will have a total of 15 minutes after that to fill up the quiz, after which no responses would be accepted. The quiz link will be posted in another minute or so. So I request Devesh now to take over the screen.
Okay. So I hope everyone is active right now on the WhatsApp group, because within 30 seconds, we'll be dropping the quiz link. It will just be a Google form in which in the first section, you have to put your name as per your certificate, your AMSA membership ID, and your email address. The second section will be a quiz section of 15 questions. And you have to submit the Google form, and then you can go for the results. If you're not submitting and your time is up, then your score will not be validated. So make a count of that. Okay. With the countdown of 5, we'll be dropping the link. 5, 4, 3, 2, and 1. Just a time update, guys. We have 5 minutes more. We have 2 more minutes to go. Okay, so last 45 seconds, then we are closing the form. Last 10 seconds. 5, 4, 3, 2, and 1. Okay. Okay. So without wasting more time, we will be introducing our guest speaker right now. Dr. Shyam Kusur sir is a DM endocrinologist from AIMS Delhi. He's an eminent personality and we are really privileged to have him here with us today. We welcome you here, sir. I would now like to give the screen to sir.
Hello, good evening to you all, boys and girls.
Good evening, sir.
I am Dr. Shyam Kishore, as introduced by Devesh. Before going to have some discussion in the recent advancement in the management of diabetes, this is really not a classroom teaching. Simply, I will give the introduction, the changes going on. But I have to ask few questions. You can answer this question after my brief talk. The question number one: who was Leonard Thomson? How many persons were involved in the discovery of insulin? What molecule in the medicine had received maximum number of Nobel Prize? And you have to name the persons who had received the Nobel Prize for the molecules. And the last question is, for the diagnosis of GDM, we have seen in our books that use 75 gram of glucose. How much of glucose we give, which is available in market in the form of the packaged form of glucose C or glucon D, how much of that glucose is equivalent to the 75 gram of glucose? There are 3-4 questions from my side. I will happy to know some answers from you all. But before proceeding to that, I would like to tell you that there are multiple changes in the management of diabetes, but it had not changed. There is not much paradigm shift in the management of diabetes. We know the diabetes since 5th century, and so we have almost gone through 1500 or 1600 years in the diabetes. And the novel molecule of treatment for the diabetes, which came into now 1922, and that molecule had received the Nobel Prize also. Not the molecule, but the scientist involved in that received the Nobel Prize for the same. And since then, there are multiple OHA had come into the market, and we are going through the many of the molecules. But there are, in the recent advancement in the management of diabetes, there are two aspects of advancement. One is the advancement in the technology, and another aspect in the availability of the treating molecule, either in the form of insulin or in the form of OHA. So there are only two aspects of the development. Briefly, I will tell you regarding in the technology, what are the technology coming into the market. Initially, we used to go to the lab for the for blood sugar estimation. Then the glucometer came. Then the continuous glucose monitoring systems came. Then after the continuous glucose monitoring system, the insulin pumps came for the purpose of insulin. Now you must have heard, many of you have heard about the bionic pancreas, which not only monitor the blood glucose level, it also provides insulin, and it also provides some hormone called glucagon for the prevention of hypoglycemia. So these are the changes in the glucose insulin technology. There is another thing, that is nanotechnology, that is providing some benefit in the monitoring of diabetes. Not monitoring of diabetes, is providing the different insulin diagnosis of diabetes, its role in diagnosis, making the artificial pancreas. The nanotechnology is also giving, trying to deliver insulin orally. That had been done in past, but not had been given the effective result. By why? Because the nanotechnology is trying to bypass the gastric effect. So these are the development in the technology part. Now I am coming to the OHA part. I will briefly give you some tips about the insulin. What are the development? Recently, we have come across the new insulin molecule. New insulin molecule had come, and that is going to be given once weekly. So coming to my slides. The recent advances in management of diabetes, we have many of the OHA like biguanides, sulfonylurea, thiazolidines, glitazars. There are many SGLT2 inhibitors, GLP-1 receptor agonists, but the drugs in the same group with the newer features are coming, and they are giving better results without having any or minimum side effect among them. Now you have come to PPR gamma agonist. Balaglitazone, this is a partial selective agonist of PPAR gamma. The another drug, vivoglitazone, it's a complete agonist of PPAR gamma. What is the advantage of this drug? The advantage of this drug is it causes less edema. Another glitazones, mitoglitazones, nitoglitazone, these are the drugs, but these drugs are not available in market. They are in the different level of the trials. The glitazars, among the glitazars, the savoglitazar is one of the drug which is available in the market, which has advantage of decreasing the triglyceride, which usually increased in the diabetic patient, as well as it improves the glycemic outcome. But there had been report of some increase in the serum creatinine level with this savoglitazar. Tagatose. Tagatose is a low calorie hexoketose group of drug. It's all the drugs. These all drugs are in the pipeline. These are found naturally in the dairy products and generated by the isomerization of galactose, and it's administered orally. But any of these drugs which will act on the carbohydrate, any form of carbohydrate, are going to affect your GI symptoms, and by that they will cause nausea, flatulence, abdominal bloating like of things. And but this drug is also in the phase 2 trials. So we all know that the glucose production is from liver is one of the culprit, and there is a insulin. You must have heard about the insulin resistance. Insulin resistance part as well as glucose production part in the liver. So our target is to treat the liver, not the liver, but we have to target the liver so that we can reduce the glucose production, and we can improve the insulin sensitivity. In this regard, we have a glucagon receptor antagonist counteract active. This glucagon receptor antagonist will definitely counteract the glucagon, and this without affecting the basal gluconeogenesis. Other drug is glucose 6-phosphatase inhibitors. This drug is definitely going to act in the liver, but the limitation of this drug is this drug may acute suppression of hyperglycemia, may cause hypoglycemia. So likely possibility of getting success for this drug is doubtful. The another group of drug is fructose 1,6-biphosphatase inhibitor. Fructose 1,6-biphosphatase catalyzes the penultimate reaction in the gluconeogenesis regulated by physiological inhibitors, AMP and fructose 2,6-biphosphate. And this AMP mimetic drugs inhibit gluconeogenesis, concomitantly stimulate glycogenolysis. So, and by this you are safeguarding the hypoglycemia. So your target is your target of AMP mimetic drug to inhibit gluconeogenesis. Advantage over glucose 6-phosphatase inhibitor, even though intermediate products in gluconeogenesis are elevated, glucose 6-phosphatase are not elevated. Glycogen phosphorylase inhibitor, inhibition of hepatic glucose production by phase 1 insulin secretion postprandially is mainly due to inhibition of glycogenolysis by the, but this is in the animal state of evolution only. Glucokinase activator. We all know the role of the glucokinase enzyme. It's an important role on the glucose metabolism in the liver by glycogen synthesis and glycolysis. It has been seen that mutation in that enzyme's affinity for glucose has blood glucose lowering effect. This SGLT2 inhibitors, this is commonly prescribed drug, wonderful drug you can say, particularly for type 2 diabetes. What happens? The maximum amount of glucose is absorbed in the proximal venal tubule. And these SGLT2 receptors are situated in the proximal venal tubule. So your target is it's at this level, and you are inhibiting the absorption of glucose, and the glucose is going out through your urine. There are many drugs in this group, but empagliflozin, dapagliflozin, and canagliflozin, these are the 3 drugs which are in market, available in the market, and rampantly prescribed by the physicians and endocrinologists. The few adverse effects associated, you are likely to have urinary tract infections. This is the most common side effect you are likely to have. You can have some extent of dehydration in these cases. Those patients who are using these SGLT2 inhibitors. This colevicelum is the bile acid sequestrant drug, depletes intestinal bile pool, increased hepatic bile acid synthesis, depletes hepatic cholesterol synthesis. This action has increased GLP-1 production, but is still not, although approved by FDA, but we are not using this drug. Now coming to GLP-1 receptor agonist, exenatide is one of the drugs which came the earliest. The advantage of these GLP-1 receptor agonist drugs are that they have effect on the weight reduction also. They have favorable outcome on the lipid profile, and they can be combined with the insulin as well as OHA. This is one of the liraglutide induced beta cell. Liraglutide is a drug. I'm not going into the detail of the drug, but this is a wonderful drug. This drug has shown maximum effect in those patients who are obese, and the weight reduction effect. Non-official use of this drug has been seen for the treatment of obesity. The tapsoglutide, another extended release molecules on once weekly basis, promising result in phase 2 study. Albuglutide. There is another GLP-1 receptor agonist drug which is semaglutide, which is now orally as oral preparations also. These are the GLP formulation and their analogs. These are the different drugs which are available. Exenatide extended release, the liraglutide, lixisenatide, albiglutide, semaglutide. These. Now I am going to insulin molecule. First we had a insulin which was bovine, then human, then we had analogs of the insulin. What we got from the analog insulin, we changed the structure of insulin, and their physiological action changed in the time and duration. So this insulin degludec, by changing the structure in the insulin, allowing formation, we used to give a hexamer formation, and this by the binding with the albumin, so it stay in your body for the long time. It's a ultra long acting insulin, and there are now preparations available with the short acting insulin with the degludec insulin. The combination will give you the immediate prandial and the basal form of insulin for your body to you. See the insulin degludec, how this, as I have told you, this how this it's in a hexameric form, and this hexameric form breaks down into monomeric form, and by this hexamers they are gradually released from the subcutaneous tissue, and it goes into blood, and it provides a constant level of insulin to your body. I would like to mention about some genetics of the diabetes also. Before going to that, I would like to tell you that recently we had come across the new molecule of the long-acting insulin, which will be given weekly, once weekly, icodec insulin. Why we are so much looking for a newer form of insulin? Because longer the duration of action, likely possibility of hypoglycemia is less. So this molecule has gone through 26-week trial, and phase 2 trial had been done versus this icodec insulin versus glargine, and it had been found that the HbA1c reduction is more or less slightly higher with this newer molecule of insulin, but definitely lower incidence of the hypoglycemia. So this is all about the newest form of insulin, which has recently been published. This article had recently been published, and it's not available in market, but hoping it will come in future. Now I am just describing some genetics aspect of the diabetes. We all know diabetes affects from the neonatal period to old age. Up to 6 months of the life, we are usually not going to get, we all know by the basic of the basic science that younger your age, you have likely possibility of type 1 diabetes. I'm just telling you the basic, but this is not the total fact. Up to 6 months of age, you have these are the genetic forms of diabetes like KCNJ11, ABCC8. These are the most common forms of diabetes. They may be permanent and or transient neonatal diabetes. We call it permanent or transient neonatal diabetes. So after the 6 months of diabetes till younger age, I'm not giving a yardstick that by this age, if the diabetes is there by 11 year, 12 year, 18 year, you cannot have type 1 diabetes. So younger the age, you are more likely to have type 1 diabetes. The classical feature of the type 1 diabetes is you are not having insulin in your body except the honeymoon period. Leave it, honeymoon period, that you are not having insulin in the body, and you are going to have ketoacidosis, ketosis. So you are absolutely dependent on insulin. Earlier, it was told that type 2 diabetes used to occur after 40, but now the age is nowhere. It had gone down even in the children. You all must have seen that what is the changes going on. Most of the kids in the society are sitting in front of the television set and eating, and without doing physical activity, so they are getting obese. And definitely one of the finest, I am not going to say the reward, but punishment by the God, that if you are going to eat in front of the television set and not doing exercise, you are not doing physical activity, in likely possibility of interacting with the type 2 diabetes, definitely type 2 diabetes. There is another form of diabetes which is called monogenic diabetes. What is this monogenic diabetes? Monogenic diabetes, autosomal form of diabetes, which occurs at around 25 years of age. 25 years of, you will have family history of 2 to 3 generations of diabetes. There are multiple genes involved in that. Monogenic diabetes type 1, 1 to 14 have been described. 1 to 14 have been described, but third is the most common. And usually these diabetes are not going to have that much of complication except few one, and they are usually not requiring the insulin. Most of them will be on OHA. So this is the list of the monogenic forms of the diabetes. As I have told you, the classical MODY, HNF1 alpha, MODY3 is the most common form of. Accelerate the onset of type 2 diabetes. It's mimic the. I will tell you another type of diabetes. So I am not going to in detail because it is not required for you all. HNF4 alpha MODY accelerate. This also MODY, that monogenic form of diabetes. The list of the monogenic form of diabetes. The KCNJ, neonatal form of diabetes. Potassium channel invading rectifier. As I have already mentioned you, it's a persistent kind of neonatal diabetes. There are many features associated in the children with this diabetes. They are relapsing type of diabetes. They will have development delay, muscular weakness, and epilepsy associated with this type of diabetes. Defective KIR 6.2 gene. ABCC8 already mentioned to you. ATP binding cascade transporter subfamily C, member 8 defect. Childhood congenital hyperinsulinism and adult diabetes, they will persist. And defective sulfonylurea at the site binding site. The FTO gene, fused toward obese mouse gene, found on the chromosome 16 in human, mutation associated with obesity, impaired glucose tolerance, hyperinsulinemia. FTO normally upregulate the hypothalamus. These are, so as I have told you earlier, the development in the technology of the in diabetes field, the inhaled insulin. Earlier, when inhaled insulin was introduced, it had not got success. Still, it is not widely marketed, not that much of successful. But with the help of nanotechnology, we are hoping that in future we may have success in this. This will definitely improve the treatment aspect of the diabetes. We will not require injection of insulin. Simply like other inhalers, we will use the insulin in the aerosolized form. The another use of nanotechnology that I have already told to you, that with the help of technology we can bypass the gastric acid effect of, so that insulin, what is insulin? Insulin is a peptide, it's a protein, so it cannot be degraded in the stomach. So mode of delivery of the inhaled insulin is through the lungs. You are going to give a large absorptive area, so relatively high permeability of alveoli and larger vascularization, likely to give a natural portal of entry into the bloodstream, and the effect may last longer. But still we have not got success in this regard. This is the name of the device which is available, Exubera. a year. Alkenes. These are the different formulations which will be available, which are available. This is the device which you can see. The absorption of inhaled insulin is as rapid as subcutaneous insulin because we are going to give the large absorptive area with the maximum vascularity. But there are few limitations of this inhaled insulin as well. Can be used in aquatic respiratory diseases? This question has to be answered. Whether it can be used in smokers or not, we do not know. Definitely, the effect is likely to be less because this has not come into market, so we cannot have phase 4 effect of this. Decreased absorption in obstructive lung disease, may even more, even in the restrictive lung disease, maybe. One advantage of this is less weight gain. As we all know that insulin is associated with weight gain and the chances of hypoglycemia is maximum with the insulin. What is the most appropriate drug for the control of hyperglycemia? The drug should be either causing weight loss or weight neutral. It should have optimum glycemic control. It has minimum side effect and there should be minimum hypoglycemia. So a best drug will qualify for all these effects. And in 2008, FDA also had issued a warning regarding the lung cancer with the inhaled insulin. This is all about which I had tried to give you in a very summarized manner, not in a detailed manner. And thank you for listening.
Thank you so much, sir, for sharing your knowledge. And I hope it benefits us some way or the other.
Would you like to?
Yes, sir. Please go on.
Would you like to have any question from these? Any of you?
Yes, sir. Basically, there were few questions we received regarding this. We'll be asking you some.
Oh, definitely.
Yes, sir. So the first question that was asked was, what is the frequency of inheritance of type 2 diabetes mellitus?
In the family, I will give you the there is a definite genetic predisposition for the type 1 and type 2 diabetes. Listen carefully.
Yes, sir.
Definite genetic predisposition for type 1 and type 2 diabetes. But in type 1 diabetes, if a single type 1, if a father is a type 1 diabetes, the likelihood of developing diabetes in a children is 1 in 217. If a mother is a type 1 diabetes and her age is less than 25, the likely chances of having offspring is diabetes of 1 in 225. If both are having type 1 diabetes, the likely chances of having is 1 in 210. But the family there is a role of genetic inheritance in type 2 diabetes, but as precisely it had been seen in type 1 diabetes, it had not been evaluated.
Okay, thank you, sir. Second question was, should a diabetic patient have strict diet or consumption of relatively higher glycemic index food like rice, mango in less proportions? Will that be okay?
I will divide this question in two parts, rice and mango. Rice and mango. Most of the fruits contains fructose. And it contains fructose, and fructose, what causes fructose? That all the fructose is not going to converted into glucose, and this fructose is going to be going into your liver, and there it is going to deposited converted into triglycerides, and it is going to cause the increased insulin resistance. So those foods which are having more fructose are likely to cause more accumulation of triglyceride, are likely to cause more insulin resistance, and by that it is not going to help you in controlling the diabetes, rather it is going to impair your the management of diabetes as far as the carbohydrate is of the rice is concerned. The most of the cereals not only contains the carbohydrate, they also contains other things also like fibers. Suppose that I'm telling, just going away from that, dal, legumes.
Yes, sir.
You must have heard about tuar arhar ki dal. The 100 grams of tuar dal, we used to tell that the dal, the legumes is the protein, meat protein of the poor. But out of that 100 grams of legume, you are only going to 25 gram of protein. So remaining 75 gram is also carbohydrate, fibers, and other contents. So this rice definitely you have to consume in it. For the management of diabetes, what you need to do, your quality, quantity. The quality should be monitored, quantity should be monitored. So the glycemic index, the minimum the glycemic index and minimum the glycemic load. Minimum the glycemic index, minimum the glycemic load, your glycemic control will be better. If you are having a food with the high glycemic index, your blood sugar will fluctuate very widely. And if you are consuming a food that is having a high glycemic index and low glycemic load, the duration of hyperglycemia will be short. If the both glycemic load and glycemic index will be high, you are going to put a very large quantity of food material that your blood sugar will be in the sustainably elevated for quite long time. So right, as per the prescribed norm of the carbohydrate, nearly 60% of carbohydrate you are supposed to consume. You can consume rice, but you are not supposed to replace all your meal with the rice.
Okay, sir. So moving forward, we would like to know the food recommendation. Basically, what could be the food recommendation for those who are suffering from diabetes?
Regarding the food recommendation, we are not going to tell anybody that you are not going to eat this and eat that. As I have told you, the quality of the food, quantity of the food, and timing of the food. You have to stick to that quality, quantity, and timing. These are the three basic facts your patient must adhere to have a proper glycemic control. It had already been briefly mentioned that the how much of the carbohydrate should be in your diet, the how much of protein should be on diet, and so you should have both carbohydrate, protein, and fat. The 15 gram of fiber should be that. Your fat should be polyunsaturated and monounsaturated fat. Your fat should not be trans fat. So these all have been well documented, how much 60% of carbohydrate to 20% of protein, remaining percent of fat, and this fat should be polyunsaturated fat and monounsaturated fat.
Okay. So next question was, what's the metformin effect on COVID patients? Is it effective in treating them?
There is only one study which had seen before going into metformin and COVID, I would like to tell you that this COVID is a evolving disease. Many, almost 100 of studies has come over the period of this past 6-7 months. Very few of them are satisfying and helpful in the treatment of the diabetes. One of the study had shown that this metformin inhibits the glycolysis by the non-toxic concentration of 2-deoxyglucose, and which attenuates the SARS-CoV replication. So you can say in that study it had been seen that the replication of SARS-CoV-2 had been attenuated by the metformin by inhibition of the glycolysis.
Okay, sir. So the question was, what is the sugar level to be maintained in treatment of foot ulcer? Should we do regular culture?
There is no different guideline except GDM for the optimum glycemic control. For the optimum glycemic control, I'm talking about adult, HbA1c of 7, fasting less than 130, and postprandial less than 180. This is the ideal. So you have to stick around these 3 parameters. First, so in GDM, there is a deviation from this. And for the foot problem, also you have to stick with these parameters.
Okay, sir.
Pardon, there was one part of the question also.
Should there be regular culture? Like,
No.
Should we do
for diabetic foot, what you need to do, if for the diabetic foot, if it is sometimes you may have, why it will be diabetic foot? Diabetic neuropathy, you have to treat that. Diabetic peripheral vascular disease, you need to treat that. If there is a joint problem, you have to, a structural deformity, you need to treat that. If there is existing ulcer without any evidence of infection, with evidence of infection, you need to treat. But at the time of taking the culture, you have to go at the base of the ulcer to take the culture, not superficially. Otherwise it will not going to help you in the identifying the proper organism. Take a sample from the base of the ulcer and give the antibiotic according to that. In addition to that, you have to provide the rest to the limb so that the ulcer will heal spontaneously itself.
Okay, sir. So another question was, will a person who has normal family will get gestational diabetes mellitus for sure?
There are few risk factors for gestational diabetes mellitus. We fall into those ethnicity group. If there is the polycystic ovary disease in that lady, if there is a history of hypertension, if there is any hyperandrogenic feature in that, but you can not only the family history of diabetes, there are other risk factors. If they are with that, they can have gestational diabetes mellitus.
Okay, sir. We have one question in the chat box. Sleepiness and drowsiness are felt in diabetes mellitus, and these functions are of the brain, and brain does not need insulin for glucose uptake. So why changes in the glucose levels affect person's brain function, like sleepiness, mentioned above, as brain can take the required amount of glucose without the help of insulin?
Directly, it is not going to affect the brain, but there are other component of the body parameters that are going, the whole homeostasis or glucotoxicity is affecting the other parameters of your body, and that will influence to your brain.
Okay, sir. One question was, can pancreas transplantation treat diabetes mellitus?
When do you need pancreatic transplant? Pancreatic transplant was first done in 1966, and till now we have reached near about 23,000 of pancreatic transplant had been done worldwide. pancreatic transplant can be done only either it could be associated with the pancreas and kidney transplant. So definitely in type 1 diabetes or long-standing type 2 diabetes, when it had become brittle diabetes, that pancreatic transplant will definitely help you. But the success story, the immunosuppression you need to give for the pancreatic after pancreatic transplant, the cost of the pancreatic transplant, all these matters.
Okay, sir. Another question was, is it possible to reverse damaged beta islet cells in diabetes mellitus 2 patients?
The beta cell dysfunction in type 2 diabetes is due to glucolipotoxicity. So younger the patient associated with the diabetes, if you are going to reduce the weight, if you are going to increase the insulin sensitivity, you are going to decrease the triglyceride deposited in the pancreas and the liver, definitely you are going to get the regeneration and renewal of the beta cell. But after the age of 30 years, it's a least likely, because the regenerational capacity of pancreatic beta cell goes over by 30 years. So you have to reduce the glucolipotoxicity by diet and reducing the body weight.
Okay, sir. Another question is, can pre-diabetic conditions in obese people be completely cured?
There are 3-4 studies: DQing study, the Finnish study, diabetes prevention program, Indian diabetes prevention program. These studies have established that if you have impaired fasting glucose, impaired glucose tolerance test, and if you are going to lose your weight, that means if you are going to improve your insulin sensitivity, definitely you are going to revert back. Metformin has also been used, but metformin has also been used for the same purpose. But the metformin is going, what metformin is going to do? Metformin is also going to improve the insulin sensitivity. So if you are going to reduce your weight, if you are going to improve your diet, if you are improving your insulin sensitivity, definitely you will revert back to normalcy.
Okay, sir. One question was, what is the reason behind diabetes mellitus causing postural hypotension?
Autonomic neuropathy.
Autonomic. Okay,
Autonomic neuropathy.
Okay. With increasing resistance and tolerance to various drugs, what is the treatment approach for long-standing diabetes mellitus 2 patients?
If for the type 2 diabetes, by the time you diagnose the type 2 diabetes, almost 50% of beta cell had gone. So by the time, so if you have started your journey with the 50% of beta cell function, so your aim has to preserve this 50% of beta cell function. So the comprehensive treatment plan for the type 2 diabetes starts from the lifestyle modification, metformin, and after metformin, there is a long list of drugs. And finally we in for the insulin. So depending upon your patient, suppose a 40-year patient, he is not that obese. He is not that obese. He will require metformin and he may require some amount of sulfonylurea. But if a obese person, he is a 70 years old, he had already exhausted all the options, you have to switch over to the insulin. But now the GLP-1 receptor agonists are one of the best drugs, which has been advocated by the many association and guidelines to be used at after lifestyle modification, dietary modification, metformin, and after that you can directly go to the GLP-1 receptor agonists, SGLT2 inhibitors. These are the drugs which are very promising drugs which you can use.
Okay, sir. Another question was, how will you approach a patient to convey a diagnosis of diabetes? What are the things to keep in mind while telling a patient they have diabetes, and how can we differentiate diabetes type 1 and 2 based on the presentation of the patient.
I have asked one question at the beginning of my presentation, that this Leonard Thompson was a boy who was 14 years old, admitted in one hospital of the Canada, and he was type 1 diabetes, and he survived 60 years after that. In 1922, he survived.
Okay. Yeah. Yes, sir.
In 1922, he survived 60 years more, 14 plus 60, 74 years. So what I'm trying to tell you, that it all depends upon your approach, how you are approaching to your patient. Tell the other guys to mute.
Guys, kindly mute, and we have a guest speaker here, and we have already told you guys to mute. So please maintain the decorum of the session. Yes, sir. Please continue.
So diabetes is lifestyle disorder going to affect your emotions, going to affect your job, going to affect your economy, going to affect your mental status, going to affect your insurance, going to affect your driving. So these are the things which you have to keep in your mind. So you tell your patient, you identify which type of diagnosis, you give proper time to him, and you show that these, I have just now told you, again I am coming to that story of the Leonard Thompson. If Leonard Thompson can live in 1922 of more than 60 years, 60 years more, then why not in 2020? It's almost 98 years. We have 98 years gone ahead. So it's a wisdom of the clinician how you approach. So you have to be very cool, calm, and patiently you tell your patient that your blood sugar levels are this. We have these options, but your cooperation is required for the management of diabetes. You have seen that there are many, you must have heard that many of your relatives are having diabetes. Many of them might have cardiovascular disease, might have diabetic neuropathy, nephropathy, diabetic foot disease. So you tell them that these are the complications of diabetes, and you are all supposed to tell that many of the patients you must have seen, they had lived a happy life and till their end. But many of them you had seen that they are not living their life regularly, visiting to the consultant for the dialysis and many things. So you have to explain the consequences of diabetes. You explain all these things. You explain diet. You explain medication, and most of your patients will be convinced at least 1, 2, or 3 visits definitely.
Okay, sir. Another question is, it's just a comic question. What is a good way to convince my stubborn father to control his diet?
You can just tell your father to find out 5-10 patients in the relation and neighborhood who had gone to the hospital for the acute myocardial infarction and who had not come back to hospital and gone there from there to the crematorium. Just, I am very harsh in that regard, that you have to tell your family members, friends, all, that these are the established complications. But one thing I like to tell you, you are not supposed to take all the food materials from his diet. Tell him you have to stick to quality of the diet, quantity of diet. Just apart from all these things I am telling you, if you are going to a party with that stubborn father for a marriage, there will be rasgulla, there will be most mithai. You tell your father you are not supposed to eat chapatis, dal, sabjis. You eat salad. Go have one jalebi, half a scoop of the ice cream, and that's all. So You have to replace your diet. So the glycemic load, not the index. You are giving some of the food with the low glycemic index and the some of the food with the high glycemic index. So glycemic load and index calculated both should be at the lower pedal.
Okay, sir.
There
Moving
was another
forward, yeah,
question.
Tanishka has one question. Yeah, go on.
There was another question that if there's a lady who's normal, but when she becomes pregnant, she gets gestational diabetes. She gives birth to a girl, and the girl is also normal until that girl's pregnancy. When that so is it possible that when the girl becomes pregnant, she will also get gestational diabetes? So what is the scenario there?
For a GDM mother, the likely possibility of her to getting permanent diabetes by the 10 years, 3, 5, 10 years, 50% of them are likely to have. The baby of a GDM mother, male or female, they are likely to have obesity, they are likely to have hypertension, they are likely to have diabetes, they are likely to have kidney disorder, maybe in first pregnancy, may not be in first pregnancy, but they are likely to have, definitely.
Thank you, sir.
Thank you so much, sir. We are now moving on to the last question, and that is it possible to prevent diabetes mellitus in a person with positive genetic predisposition?
I have told you that if this is the monogenic type of diabetes, you are not going to prevent. But suppose if a family of diabetes, if my father is a diabetic, he is 60-year-old. If he's 60-year-old, 80 kg, he is diabetes. I am 30-year-old and I am 80 kg. I am going to have diabetes. I am predisposed to have diabetes. So if I reduce my weight, I improve my diet, I do regular exercises. At the age of 30, if I lose my 20 kg of weight, but according to my height, if I maintain myself under the BMI category, definitely I'm going to prevent.
Okay, sir. So here we will be closing the Q&A session, and furthermore, if there are any other questions that needs to be answered, you can anytime text any of the group admins on WhatsApp, and we'll get back to you with answer from the guest speaker. Right now, we have group discussion, so we will be moving forward with that. So thank you so much, Dr. Syamgusho, for enlightening us. And I would
Any other
ask,
question?
I hope no, sir, because we have already exceeded the time
Good
limit.
evening, sir. Sir,
Yeah.
can I just ask one question?
Yeah.
Sir, I wanted to know that you told that hypotension is due to autonomic neuropathy, but
Yeah.
how can we be so sure that autonomic neuropathy is due to the sympathetic discharge or parasympathetic discharge?
You have one predisposing factor, diabetes. We have one predisposing factor, diabetes, and diabetic patients are likely to have autonomic neuropathy. That's why I'm telling you.
Okay. So can we move forward with the results, Nandini? Are we ready?
Yes.
Yeah.
So
You can screen share and let us know the
Screen
results.
share.
Yeah.
thank you, Devesh. I'll start sharing screen now to
Yeah.
showcase the results of the top 48 rankers that will be divided into 8 groups of 6 each. So just a minute. Okay. So yeah, like I said, it's the list of 48 top 48 in no particular order into 8 groups. As soon as I say your name, you're supposed to rename yourself on Zoom according to this format, which is team number, as in the example here, team number 1, and underscore, and then your name. If you're not on Zoom currently and you're watching this from the YouTube live, then I suggest you change your name to this and then request for access, and we'll admit you. So as soon as I give out the list, you guys are supposed to rename yourself like this. I hope I'm clear. So these are the team 1 attendees. Kanika Bhargava, Devang Agarwal, Shrishti Lodha, Sohail Thapar, Gayatri AS, Veda Pratyusha Thot. I hope I'm pronouncing these right. If not, I'm really, really sorry. Okay. Team 2. Madhav Goyal, Mohan Raj G, Aditya Kalwaghe, Kartavya Singh Yadav, Hunur Mahal, Archika Shukla. Then team 3, Mohit Goyal. There was no surname for this, but we kind of saw it in the email, so I hope it's right. Dinesh A, Yuvashri S, Shubham Mishra, Pranjali Singh, Anandan Nathana. Then team 4, Abhijit Ragha Tate, I don't know, Siraj Sachdeva, Lavalina S, Larika Kumar, Kashish Malhotra, C.S. Vishnu Thebar. Team 5, Abhavya Jha, Shubhra, Sushita Kataria, Himanshi Gupta, Abhilasha Tyagi, Saliha Muhammad Ali. Team 6, Ishika Agarwal, Sneha B, Ritul Kapoor, Diljot Singh, Afzal Parvez Khan, Astha Singh. Team 7, Chati Sharma, Pragya Shikha, Kinari Shah, Shruti, Satyajit Singh, Karan Chaudhary. And lastly, Team 8, Srila Srinivas, Raja, Sakshi Gupta, Ananya Vadera, Pooja Meena, Ajay Shinoy, and Bhavya Khatri. So congratulations to all of you. And yes, this is a reminder for all of you to rename yourselves on Zoom according to team, then the team number, and then your underscore, and then your name. Yes, we'll be waiting for that to happen. And for everyone who's not on Zoom and on YouTube, I suggest that you guys send us please click on the link and come to the waiting room and we'll admit you. So we'll just wait for that. And I would again request you all to rename yourselves as fast as you can, because if you fail to do so, then we won't be able to give you the respective breakout rooms and that would lead to disqualification. So thank you so much. And as soon as we're done with this and the renaming, I think I'd like Aditi to start with the instructions for the group discussion. Over to you, Aditi. You can start. This reminder will be up there.
Okay. Yeah, am I audible?
Yes,
Yeah.
you are.
Am I completely audible?
Yeah.
Yeah, thank you. Hello once again, guys. We're finally at the last stage of our event, and we hope all of you are super, super excited and pumped for the group discussion. We have Honorable Dr. Shyam Kishore sir with us to be the judge for the group discussion. Now, let me tell you how the GD will actually proceed. You're all divided into 8 teams with 6 participants each, as said, already told by Nandini. Now, you will be sent into breakout rooms for the group discussion for a total of 20 minutes, guys. Keep in mind 20 minutes. After 20 minutes, the breakdown room will collapse automatically. We would request everyone to please complete your discussion within the time frame. Now you will have to select one participant from your group to represent at the end of the session. This person will actually be summarizing and presenting the whole discussion of the respective group, for which he will be given a total time of 3 minutes. Now here, after the speaker finishes speaking, Dr. Shyam Kishore sir will ask questions to the presenters if he feels the need to. Now, moving forward, some norms to be considered. Now, do not exceed 3 minutes, as that would lead to a deduction in points. We will directly stop you at exactly 3 minutes. Now, the presenters will be called up randomly, so we would not be following any kind of sequence. Please please complete all the discussion in the breakout or the co-host privately. With this, one facilitator will be managing 2 groups and will be solving all your queries. Now, what are we exactly expecting out of this GD must be the question running through your mind. So let me answer that. The topic for the GD is prevention of diabetes mellitus type 2. But mind here, we are not looking for the common answers, the common and more ideas that can actually be implemented to curb this impending pandemic. Now, we will now be dividing you into breakout rooms, and we hope all of you have fun and learn something out of the group discussion. All the very best, guys. Guys, we'll be like distributing you into breakout rooms in a minute. Please stay tuned.
Hello, I'm Ananya. I didn't hear the topic clearly. Could you repeat it?
Yeah, sure. Yeah, so what we are exactly looking from you guys is, see, the topic for the GD is prevention of diabetes mellitus type 2, but we're not looking for common answers or common words such as junk food. Everybody knows that. So what we're exactly actually looking for are some very creative ideas, and most importantly, practical ideas that we can actually, implement ourselves to. I hope it is clear now.
Yes, thank you.
Yeah, my pleasure.
Please first rename yourselves and then, come into the waiting room, because then we won't be able to admit you.
Also, one more reminder that the format has to be correct. It has to be team, then the team number, underscore, and then your name. If it is in any other format, like your name underscore the number, team number, then we will not accept that. So make sure you get it correct.
Guys, please wait for a few minutes. We are just done with all the breakout rooms, and like you'll be added soon.
Okay. So I'll be releasing the breakout room now. And if anyone wants to join, team members, if you want to join, you can anytime come in the Zoom and we will add you in that breakout room. No worries. For now, we are opening all the rooms. By the time we are having the group discussion, you guys can join after 20 minutes when the speakers will put forward their points and the guest speaker will judge and announce the winners. Thank you. Is anyone of you here was in a team earlier and haven't joined the breakout room? You can anytime change your name and I will assign you to that room. Change your name to your team number and then your name. Okay, guys, is everyone here? The group members. Can we know the group speakers of team 1, please?
Hi, I am Sohail Thapar.
I
I'll
am
be
the
the
speaker of Team
speaker
4.
for Team 1.
Okay. Team 2. I would like to tell that each and every group speaker, whether it be group 1 to 8, kindly put your cameras on to present.
Yes, so I suppose everyone's here now.
Let's
Welcome
have all
back,
the group. Okay, let's have the group speakers
Yeah,
on the camera first, then we can start.
Yeah. Okay.
Okay. Team 7, Karan, are you presenting?
Yes, sir. I'm ready.
Okay. Okay. And team 8, Ananya and Bhavya, who was presenting? Okay. Team 6.
Hello, I'm presenting.
Okay, thank you so much. Team 5.
This is Saliha. I'm presenting.
Okay. Team 3, anyone? Okay. Team 2.
Team 2, Madhav, I'll be presenting.
Okay, nice. I think Aditi, we can move forward with the GD.
Yeah, sure. Am I audible?
Yeah, perfect.
Yeah, thank you. So welcome back, everyone. We hope you all are now prepped up for the presentation. We will now be calling everyone randomly. So there is no sequence. Now, when your group number is called up, the representative of that group has to mute himself and can then speak with a time limit of 3 minutes. And as explained earlier, we will be stopping you at exactly 3. Okay, so let's get started. So the first theme coming up will be group 6, followed by group 2. Let me repeat. The first theme coming up is group 6, followed by group 2. So group 2, please be prepared.
Ritul, can we start?
Okay, fine. Okay. Hi, everybody. I'm from group 6, summarizing this thing. So let's start. So one thing
Okay.
that we really found it evident that India is the diabetic capital of the world, and soon we are going to move into pandemic. So we decided to stop on few points which we think will help us to prevent the stage for happening. So first thing that we came upon a discussion that rather than diagnosing people more and more people out of the diabetics, we should concentrate on the pre-diabetic stage, and we should only diagnose them on the pre-diabetic stage, so that whatever the damage that is to be happen in the future could be prevented, and we can reverse them to a normal lifestyle. So we want more and more testing of the people, just like all the programs that government has undertook for polio, for different diseases. We want doorstep that government people should come to doorstep and check people for glucose, so that they could be diagnosed earlier and we could prevent them from moving into diabetes. And the second thing that we agreed upon is that whenever, like, you have seen that for every tobacco product we have this advisory written on that it causes lung cancer. Similarly, the foods which are given from the food department in India should have a this high glycemic index advisory, so that people could at least know that eating these foods will further lead them to a exposed to different diseases, not just diabetes, but different other diseases of, the strong eating habits. Further, that I want to highlight a proper counseling for the people who have been diagnosed with diabetes and the parents who are diagnosed with the diabetes, the gestational diabetes mothers, so that their future offspring, they know that their future offspring is going to have this risk, and they can further educate him or her so that he could get easily checked up and the situation is a bit reduced. And then upon the few last points is that instead of promoting a cracker free Diwali, we should also promote a cracker free plus sweet free Diwali, so that people should, lower down their instincts of having sweets and all, just concentrate on a better eating habits. And the last thing, if the people are diagnosed with the diabetes, so we should have a dietitian and a psychologist integrated with the endocrinologist, so that the people could have a psychological health and also a dietitian help, because every diet should be unique to the person who is suffering from diabetes, right? And the last thing that I would personally want to promote, that on social media we have so much wrong body image campaigns that portray a woman that is very satisfied and happy with the fat body image, and it is considered as having a good body image. So I guess that is a wrong portrayal of body image, because body image should be something fit towards fit. I mean, I'm not discouraging the person to have a good will about how they are, but of course they should be told about that, how to make them better and to be
Okay,
fit.
and it is time. And it is
Okay,
time.
that's all for my side.
Thank you so much. Group
Thank you
6,
so much.
Ritul.
Yeah, thank
Sir,
you.
you have any questions, sir, for that?
Just now she had mentioned we have a maximum number of diabetic in our country. You tell me which country is having maximum number of diabetes in the world?
India is the diabetic capital of the world, so I guess India.
No, wrong. You have not. You just now you have mentioned that one more thing, that you have planned to find out the pre-diabetics.
Yeah.
Will you go to investigate each and every person with the blood sugar level, or you will put some yardstick that so that these persons will be in?
Yes, sir.
You will check their blood
Exactly,
sugars.
sir. Yeah, exactly, sir. I just want that this test should be actually made free for all the people, so that
I'm
we
not
could have
asking about the
accessibility.
free cost. I'm not asking about the cost.
Yeah.
Suppose you are living in a community of 1,000 persons. So you will do blood sugar level of all 1,000 persons, or you will put some yardstick, you will put some criteria for making investigating their blood sugar level.
Yes, sir, of course. If we have such a population, age-wise, the middle-aged people and the elderly people who have much more risk of getting diabetes should be, I guess, checked first.
Now one more thing. Suppose you have come to know that in this community of 1,000 people, there are 50 persons or 100 persons spread over many family are diabetic. Will it be possible to go and meet each and everybody? Then how you will interact with them?
So basically, I would prefer, like, if every person who would come for a test and when they would get a report, they should be told that you should, make this modification in your life so that you would
Just I am
prevent
simplifying my
diabetes.
question.
Yeah.
How you will interact yourself at a community level?
So on a community level, we can plan a webinar, like if we are doing online, or we can go to that community and we can plan a campaign, or we can plan something known as Nukkad or something, which would help people to create awareness that this is also evil, silent killer.
Chalo, okay.
Thank you,
Okay,
sir.
now moving on to the next group, group 2. Team 2, Madhav. Anytime when you're ready, just tell me.
Yeah. Okay, so start. Good morning, everyone, and good morning, sir. My idea of prevention would be dividing people into various categories, assessing them on the basis of what categories do they belong to. Like if a person is having a risk of genetic predisposition, we could do a pedigree analysis so that we could educate them early on what all risk factors and what all things do they need to avoid in their lifetime. Psychological help could be a great thing in this, because they will definitely have a chance of being obese and definitely have a chance of getting diabetic at some point in their lives. And then comes a category of high risk patients. High risk patients are the pre-diabetics, should be advocated lifestyle changes initially. Development of diabetes could in the future lifestyle will be important. So regular assessment of their diabetic levels is also important. So thirdly, the people who are already having diabetes, the people who are already having diabetes should be assessed regularly so as to through HbA1c and fasting glucose levels. Fourthly, the people who are pregnant. Pregnant people should have an oral glucose tolerance test regularly and should be taken care into that they do not go into complications. So the regular test for them as well. Then we could also take care into risk factors. Risk factors like obesity, hypertension, alcohol, smoking. So the obesity factor could be like managing their diet, controlling the diet and giving them a balanced and a healthy diet, dividing them their plate into proportions, like giving them the diabetic proper diet. For the hypertensive people, we could always check their regular blood glucose levels so that they do not fall into the hypertensive category. Then avoiding alcohol and smoking in the people who are at high risk or diabetes, or the people who are pregnant. Then we could also suggest them to limit their calorie intake and inform them and educate them about the high glycemic and the low glycemic index foods. Then we could also inform them about like educating them to have regular checkups with the doctor so as to get assessed on every parameter. Moreover, we discussed like we could have a program in the schools for 10-minute exercise regularly so that they can improve their lifestyle. The students do not have a risk of diabetes further on. uh, mm, I think that was it. I think.
Okay. Thank you, Madhav, for your insight. Yes, doctor, if you have any questions.
Yeah. Whom he will put into the high risk group? Whom you will put in high risk group?
Sir, we can actually put the people who are at like genetic predisposition of diabetes. We can also put like the pre-diabetics in that category.
Would you like to follow up the GDM patient after delivery?
Yes, I would like to follow that patient because he is an increased chances of like falling into pre-eclampsia and eclampsia, I think.
After delivery?
Uh, During the delivery, I mean.
My question is, would you like to follow the patients of GDM after delivery?
Yes, sir, I would like to follow them after delivery because mostly like they could develop diabetes after that. After gestational diabetes, they
You
could.
are you are making a discharge of a GDM patient. If you are sitting in a hospital and you are making a discharge of a GDM patient, what advice you will give to her?
Uh, Sir, to follow a proper diet after that, to look for complications in the neonate, so that if she had GDM during the pregnancy, the neonate could develop complications because of the increased glucose level. Then to take care of the glucose levels regularly in order to just the doctor needs to take care of that. Any comorbidities that she already has, she needs to take care of that as well.
Okay. Bye. Thank you.
Thank you, sir.
Take.
Okay, moving further, we are going with group 7. Who is presenting from group 7?
Sir.
Okay. Anytime when you are ready, just tell me, the timer will go on.
Yes, sir, I am ready.
Okay, the timer starts now.
Good evening, everyone. As after group discussion, we have collected some 10 points regarding the prevention of diabetes mellitus type 2. So first point is the family history. Family history, we are mainly targeting on the person who are more prone for the diabetes type 2, as it can travel through family, and asking the children of that family to work on their diet and regular exercise from the beginning to prevent this disease. Second point is awareness program. As we see in India is one of the country with having maximum number of cases. We should put some programs for awareing people about the severity of the disease and how to prevent it, how we can stop it, what are the measures we should take. Third point we added is a stress. We as learned in the webinar that stress is also a reason for causing diabetes type 2. So awareing people about management of the stress and work-life balance is very important. Fourth point we add was a lifestyle. It included a proper sleep, exercise, regular eating, and we also added some supplements like green tea, which can actually help in boosting our metabolism. Fifth point that we added was scheduling days of our life. As sir had told that timing of food that we take is very important in preventing the diabetes. So we added this point that a person who is more prone or any person who want to prevent this disease should um, make a proper schedule of their day, when to eat, when to work, when to sleep, and when to work out. So this can add a great measure for preventing it. Sixth point we add was regular monitoring of glucose levels in the blood. So maybe it is not possible for all, but those people who are more prone and have more chances for having diabetes type 2 can go for this test regularly. Seventh point was about the sedentary life. As we see, the diabetes type 2 is also called as the adult onset disease, but it's begin in the children's, and the signs and symptoms appear in adult. So we can target this group, age group of children's, and as children's nowadays sees that they are more involved in the high technology and less in the sports like swimming, running, etc. So they can be the cause, and we can prevent it by awareing them, as children are not very aware about these diseases. Eighth point we had was the diet changes during different stages of the life. As
And your time stops. Okay, I guess.
as that it childhood
Yeah.
part, science and symptoms appears in the.
Karan, your time's up. We're really sorry. The next theme will be coming up is group 1. Sir, if you have any questions.
Yeah. How green tea is going to help?
Sir, we don't have that much of broad knowledge about green tea and diabetes.
You have mentioned, na? You have mentioned. It's a common sense. It's a common science. You would apply.
Yes, sir. We have not done any research that whether green
how much of exercise you will advocate to your patient? How much of exercise you will advocate that you should do in a diabetic patient?
In a diabetic patient, okay, so in a diabetic patient, enough exercise that can maintain their fatty acid level.
How much enough? Enough is not enough.
30 minute walking or 45-minute cardiovascular exercise is good enough.
Okay. Move on.
Okay, so the next group is group 1. Can we have the representative of group 1, please?
Hi, good evening, everyone. I am Sohail Thapar from Team 1. I hope everyone is safe and healthy.
Yes, you are audible.
Tell me when to start.
Ready, please let me know and I'll start the timer.
Whenever you're ready, I am ready.
Okay, so I'll just count down to 3 then.
Sure.
Yes. Okay, 3, 2, 1, go.
Okay. Hi, everyone. Since childhood, this one thing that we have heard from starting is health is wealth. Health is wealth. This is one thing that we've heard from the starting. But the sad reality is, and Thomas Fuller very rightly said, that health is not valued till sickness comes in. And that is the truth of the entire world, as a matter of fact. Until unless you are suffering from diabetes, which matter of fact is one of the leading cause of mob, is the 6th leading cause in the world, and India is the diabetes capital. So and still people do not realize the importance. So I feel something that is very important is to instill this in the brains of young minds, the minds that are easily meldable, that the importance of health and the importance of controlling diabetes it is. When we talk about prevention, we'll talk series wise. So we'll talk about the primary prevention, which is to not cause diabetes. So we'll talk about children, which are the future of this country, the future of this world. When we talk about children, the number one cause is obviously obesity. We've heard about that. We know the comorbidities. Obesity is the number one cause and the number one risk factor. So curbing obesity in children, which is on the rise, is very important. So how do you do that? So instilling exercise in your daily life and eating healthy. Of course, you cannot force a child. No child wants to eat green vegetables. Everyone is choosy about what they eat. So making these vegetables interesting, making carrot cakes, or having different ways, or food coloring, something to make the make food interesting. Or if someone wants to eat if someone wants to eat something sweet, everyone has a sweet tooth. So rather than having chocolates or cakes, you can instill in the child from the beginning that something sweet is fruit. Fruit is a natural source of sugar. That is, of course, it's sweet, but it's much better than a chocolate that can provide, or a cake that the amount of health that the cake can provide. Then we can have reward system. The increasing risk of diabetes is because is because of the change in lifestyle. We are going towards a more sedentary lifestyle. We spend our times glued to the screens and looking at our phones. So having reducing the screen time and having a reward system. So for example, saying someone that if you play for 15 minutes, or if you play this sport for a day, you'll get 15 minutes of screen time. Having this will actually inculcate in the child that yes, sports is something that is interesting and it'll give me a reward as well. And then having a shift in the curriculum. So in schools, I know education is very important. It's what forms the basis of a child. But having a shift towards a more practical curriculum rather than a more textbook curriculum is what's going to keep the child active and on its feet, and that will have a habit of always moving rather than staying sit and looking at a book. Then going towards the general public, the adults, awareness is one thing we have
And
to
your
look at.
time is up,
Okay, so
Sohil. Your time's up.
okay, my time is
Sorry.
ending, so I'll just
The
end it
next,
that diabetes is a word and not a
yes.
sentence.
Um,
Okay, so any questions, sir?
okay, thank you so much. I would urge the next group 4, to be ready. So, and do you have any questions?
Yeah.
Yes, sir.
You have mentioned about the fruits in diabetes. Which
Yes, sir.
fruits you will advise to your patient for in diabetes?
Sir, if someone is a child, needs to have a wholesome
You
nutrition.
tell me the name of the fruits which you will prescribe in a diabetic patient or in a child which is not going to harm
Okay,
him
sir.
or
So
her.
having a high fiber fruits like apple, for an apple a day keeps the doctor away. So having an apple is very beneficial.
In addition to apple, any other fruits?
I mean, if you talk about high fiber fruits, then banana has very high fiber and potassium, and we have to avoid fruits such as mangoes or grapes, which are very high in sugar content. So yeah, basically.
How do you propagate the awareness of at the level of community?
Sir, I was getting to it. So basically, sir, we can have okay, we have a corporate atmosphere right now, right? So everyone is doing corporate jobs where they go 9 to 5 and they work and then they come home, they sleep. That is their lifestyle. So if you're going towards your work, rather than using cars, walk, or if you're in a very big city, use public transport. Public transport is something that,
These are the measures of lifestyle changes. Rather, I have asked you how you will make community aware of
okay,
that
so having,
diabetes is
sir,
such a
awareness
silent killer.
programs. So I was getting to it, sir. So there are corporate retreats, and then there are mass festivals where people are in large gatherings. So these are the places where we can go and make people aware, because awareness is the key. If people do not know what is the importance, because yes, if person has diabetes, he will know everything about diabetes, but the person who does not have diabetes doesn't know anything about it. He's not concerned. So making them
Okay.
listen to it is what is going to change their mind.
Okay.
Thank you so much, sir.
Okay.
Thank you. So the next group will be group 4. Can we have the representative of group 4, please?
Hello,
Yes.
I'm audible.
Yes, you are completely audible. Please let me know and I'll start the timer when you're ready.
Hello, everyone. I'm Kashish Malhotra and I will be representing the team for today. See, we believe that the screening of disease is the most important thing which you can do because diabetes is an insidious onset. And also at the time when the patient is told that, okay, he's having the diagnosis of diabetes or pre-diabetes, it is the golden time at which we can tell the guide about the patient because patient is critical. Okay, he's having some disease. He needs to further look upon that. At that time, the patient is very cautious. We need to guide him there at that time. And also, like if you're considering a screening camp, we think that we should need to create a local community to further enhance our efforts. Because see, the local community will act as a positive motivation, and further local community can volunteer in the nearby communities too. Because as a doctor, I cannot be there at community all the time. But the community, but the local leaders will be there all the time. And further, have the local leaders. We need to create the local leaders out of the screening camp. Like they don't know me, I'm an outsider for them. But if you consider a local leader, they know him for more than 10 years. So of course he will have much more influence. Local act as our propagator. Like he can spread the positive message. And further, like these local leaders can weekly interactive meetups and they can keep a check on their neighbors. Like, okay, the local leader can say, okay, so you have not following. He can ask his neighbor, okay, you are not following this.
Okay, there might have been some internet connection issues, I guess. Yes, so shall we move on to the next speaker? Like if he comes back, we'll give him some more time, I guess. Like that's okay. So can we have the speaker
Hello.
of the representative of group 8? Okay.
Hello,
Okay.
am I audible?
Kashish, yeah, you're
I
back.
guess team 4 is here. Yes.
Yeah, I'm
Yes,
sorry. I
please
don't
go
know
ahead.
like what is happening. I'm really sorry for that. See,
It's okay. Please
okay.
go
Okay,
ahead.
See now,
and you have 1 minute 20 seconds. You can move
And
forward.
one,
yeah, okay.
yes, you
See,
have
we need
one.
to create these local leaders. Like these local leaders can further enhance. They can keep a check on their neighbors and the local community because they know the community much better than me. And also they will have much more influence. And also like we need to tell them about this. What happens is the backward areas, like there is some local babas who are selling medical medications. It doesn't work like that. It can only be controlled, not be cured. And also like we should inculcate the social values. Like in Punjab, we have these makki di roti sarson da saag. It can be also much more in a much better way can be implemented. You can have social values also with that. It will be much more easier than that. And also like we should also take it as an opportunity to guide the whole of the family because it also has some genetic preponderance. Okay, there's one patient. We should also talk about the attendings if he's like his son or daughter. If it was his brother or sister, we should also tell them about that. Okay, you are also at high risk because there is some genetic preponderance in diabetes. So you should also tell them. And of course, we should tell them about the diet and exercises. We can talk about that like right now, yoga and regular exercises, 30 to 60 minutes, 3 to 4 times a week. And then I would like to conclude that see we should have to take a trifecta approach. The first part is at the community level, what the community needs to do. Then as a doctor level, as a doctor, what I need to do. And then is the policymakers or the officials. Like as policymakers, they should need to tell that okay, this food has high glycemic index because it will also act as an awareness. As if I only say okay, only me as a doctor I can do it, it is not possible. Like this initiative by AMSA also is a very great way to further create the awareness. So I think it needs a combined effort of the community doctors and policymakers to prevent the
Okay,
diabetes.
and that is the time.
Yeah, thank you.
So if you have any questions, meanwhile, we'll be moving forward with group 8. Be ready. Yes,
You tell me one thing. If father-son duo coming to your clinic and father is having diabetes, what probable information you are getting from the father and what information you are going to give to the family?
See, if the father is coming as a patient of diabetes, first I will need, when I will talk to him, I will definitely consider social history. Okay, so is there a prevalence of alcoholism? Is there a prevalence of smoking? His father is alcoholic or his father is a smoker? I can also get the social history. And of course, all the medications are different stuff. But then I will talk about the son. Okay, see, as your father is a diabetic, you are also having an increased chance. So you need to be behavior. And I will, of course, not only like tell him like in a very severe way, but I will tell him that be cautious, keep your BMI less. I will talk about, of course, I will not tell in this professional language. I will talk in the local language. Okay, that you should talk about, you should have some good medication, you should play, you should enjoy, and that's it. Don't take much stress, because stress is also, of course, a modifiable factor for diabetes.
One more thing, tell me the role of school in diabetes prevention program. Very
School is-
briefly, how
Yes, so-
a school can help in diabetes prevention program. There are only, you mentioned 2 points.
So it is the most important thing. Like GOS is like, it will control the future generations. As I said, we need to create a community leaders. Like the teachers will be community leaders. Students are somewhat, they listen to teachers. So their teachers will be the community, will be the local leaders there, and they can directly talk to the children. Okay, see, if you want to have a good and healthy life, you need to control what you eat, and you need to exercise daily. So I think that schools are most important thing. Like teachers should act as the local leaders, as I said in my screening camp program. And I think in this way, it will create a awareness and a positive motivation around the whole of the community.
Okay.
And can further spread. Yeah. Thank you, sir.
Okay. Thank you so much. Moving forward, we have group 8.
Yes. Hello, am I audible?
Yeah, you're completely audible.
So I want to share my screen if that's okay.
Yeah, that's okay. Yeah. Are you able to do that?
Yeah. Can you see my screen?
Yes.
Okay. Great. So you can start the timer now.
Okay, your time starts now.
Good evening, sir. Team 8 will tell us the innovative methods that we've thought of for prevention of diabetes of type 2. Can you see the change in my slide? Okay.
Yes,
So
yes.
the first thing is that prevention is better than cure, and all of us know that. And the second thing is that if you educate people through webinars, then the reach is less and there's not individual attention. So for diabetes, and because it's going to become an epidemic, it's necessary that we focus on individual diagnostic methods. So we want to try to build family monitors. That is, one person from a family who we will train. We'll give them manuals and helpline numbers. The manuals will contain essential information related to diabetes, for example, BMI, for example, the risk factors, for example, Indian dishes that can be given to diabetics so that, or pre-diabetics, so that the glucose level stays less, and other methods on when to screen and how to visit doctors. We can also give them doctor numbers in the manual and guideline. So there'll be one person from family monitors, and in this, we will also include a lifestyle change program. This already takes place in the US. So basically, we will have health camps as medical students and as doctors. It's the best that we can do to have health camps. And the best way to inculcate this, especially for medical students, would be that to make this compulsory for our curriculum, that we have to have a health camp related to diabetes and educate people in that health camp. And another thing we can do is for people who have asymptomatic, who have risk factors and are asymptomatic, we could give them a glucose screening test. And then we have for people, the most commonest is in the urban areas, while the second commonest is in the rural areas. So in urban areas, most people have access to internet. So we could take this online. We could have a website and we could have apps. And both of these will work as in forming a group of people who maybe have diabetes, have recovered from diabetes, or had pre-diabetes. And in this, they will talk and give suggestions, give advice. And in this, the best thing that we can do is have a moderator who could be a student, who could be a doctor, a trained student or doctor, and they could help guide conversations in case there are any problems. And social media is our strength in today's world. So on social media, campaigning is necessary. We have to spread information about diabetes through social media. And challenges. Most people are interested in challenges. So we could have a challenge, for example, cook a food which has low calories or low sugar and post it on social media and challenge your friends to it. The other thing that we can focus on is definitely schools, because children learn from what their parents do. If parents follow an unhealthy lifestyle, then children will also follow that lifestyle unless we intervene. Unless we educate them about what is right and what is wrong and how you can actually prevent a disease like this, which has a lot of modifiable risk factors.
And team 8, your time is up.
Okay,
team 8, your time is up. We're really sorry. Meanwhile, team 3, Please be ready. You'll be presenting next. If you have any questions for team,
what changes in lifestyle you will advise to your patient?
So changes in lifestyle will definitely be to be more active, to eat less foods that are rich in trans fat, and to exercise daily, and to take less stress. These are the modifiable risk factors. And if they smoke or drink, definitely to not do that and cut it down if they can, and definitely not in front of their kids.
What are the benefits of prevention program?
Prevention program, it's from the root. We don't wait for diabetes to happen. We prevent it just at its root. So through the lifestyle change program, we can help especially for people who are pre-diabetic, we can help them not to go into the diabetic stage. And for diabetes, we can help them not develop neuropathy and signs like that.
Okay.
Thank you, sir.
Okay. Thank you so much. The next group will be group 3. Can we have the representative of group 3,
Yeah, hello.
please?
I'm Yuvashi and I'm presenting for Team 3. Hello?
Yes. Whenever you're ready, please let me know.
Yeah, you can just start. I'll just start.
Okay,
hello.
Great.
Okay, the first thing that we've come across is the family history. So we are going to group people into various categories. So first is the family history. So all those people with family history, we are going for pedigree analysis so that we could diagnose diabetes for them. And then we are coming to the diet modification. So today we have more awareness of different diets which are present. So we would like people to regulate the quality and quantity, and also the timing in which they take their food. So scheduling of a daily activities comes here. So not only that we're supposed to schedule on what time we are consuming our food, it's also about the sleep timings. So nowadays our sleep timing is really altered, and we also need to schedule all our sleep timings, because even late night sleeps can are found to be a cause of diabetes. So maintaining a good sleep routine is necessary. And as the quote goes, keep smiling, stop worrying. Nowadays, it's more of worrying than smiling. So stress is one of the major problem, not only for diabetes and for various diseases. So we could organize meditation and all those stuffs. So we're coming to meditation and exercise, all those things. So it's not only about an individual person. Generally what happens is that if a person is diagnosed with some disease or illness, only then that person would start exercising or following a particular diet. So what we can do is that we can have some family or friends who come together and they start performing various activities which are useful. And then we can also one of the major thing that we can do is conducting sessions. So wherein we most of the people don't have an idea of what diabetes can do to them. So we can have webinars and activities which would help people in creating awareness. And then we'd come for screening of diabetes. So screening in earlier stages is actually important. So generally people won't come to us when they're asymptomatic. So for all those asymptomatic people, they won't be willing to do blood tests regularly. So one of the things which I went through and saw in one of the pilot studies was that they've designed a tattoo which detects the blood pressure, blood glucose and the markers for diabetes. So what happens is that when the person is about to get in pre-diabetic and diabetic stages, that tattoo, the color of the tattoo changes. So such measures can be done for monitoring the glucose. And last, the main thing that we have discussed is that awareness. Awareness is the most thing. So the first thing towards change is awareness, and the second thing is the acceptance of what we have to do. Thank you.
Tell me, what are the medication which can be used for the prevention of diabetes? At least two.
First, we'll start with metformin, and if it's not working, then we'll go for insulin.
I have asked you, tell me the medication which can be used for the prevention of diabetes. Can be used for the prevention. One you have rightly mentioned, metformin.
I just know metformin.
Metformin is the right answer. Other than that I have already mentioned to you.
Maybe you can have some high fiber diet and all those things.
No, that is the part of the diet. That is the part of that. Okay. Next.
Okay, so the next group is group 5. Can we have the representative of group 5, please?
Hello, am I audible?
Yes, you're audible. Let me know when you're ready and I'll start the timer.
Okay, I'm ready now.
Okay.
Good evening, everyone. Diabedemic. Yes, diabetes is emerging as a pandemic, so we need to clearly look into it. Definitely, prevention is better than cure. Importance of diet modification must be brought in, not just among the people who have family history, but also among obese children or children in general from schooling itself. And even food chains must not a calorie count along with their menus, so people can be a bit more health conscious. And food shows and programs must focus on healthy menus to promote a healthy food habit among people. As we know, exercise can be beneficial. Similarly, importance on mental health must be stressed. Like we need to promote yoga and meditation. That must be given importance, especially among students who have very stressed because of education system that is yet to be developed. And I would say mental health groups must be developed to make diabetic people aware that control is possible. Diabetes is not end of something. A control is possible. Better healthy living is possible in future if properly controlled. A positive mindset is very essential for that. And mental health groups must develop so that children with high BMI will start losing weight, will start concentrating on their health, and they will lose weight, and so that they won't get diabetes in future. And I would say initiatives by NGOs must do regular blood checkups just to find the pre-diabetic condition among people and to make sure they don't worsen their condition. And I would say that government and NGOs must look into the shoe matter. That is something that's not stressed at all, I would say. Diabetic foot ulcer is a very common issue among uncontrolled diabetic people. So shoes must be made available to the people so that they won't get foot ulcers, and amputation will not happen to any person. And another innovative technology that I would like to mention is about developing nanotechnology in future. So micro robots can be developed, which can actually micro robots once introduced into a bloodstream must be able to monitor our blood level, and along with can release insulin at the same time. So it can be a better cure in future. And if possible, if the micro robots are biodegradable, it can be introduced into the bloodstream like every month or once in 3 months. So it will be a better cure, so that many people in the future could say that yes, I used to have diabetes, now I'm better. I'm I having a better living now. So that's thing I would like to mention regarding new innovative measures.
And that is time.
Thank you.
Thank you so much for your presentation. And so if you have any questions.
Tell me which country in the world is the diabetic capital?
India is the diabetic capital, sir.
And which vitamin has likely to be role in the prevention of diabetes?
The white.
Okay, no issue. Any most commonly used drug which is causing hyperglycemia, most commonly rampantly used at the primary care level, tertiary care level, at the level of QAC, for many use.
Sorry, sir. Could you repeat the question?
Yeah. Tell me the name of medicine or drug which is rampantly used at all level of medication in the different departments, which is commonly causes hyperglycemia and finally culminating in diabetes.
Is it anything regarding the primary measure like maintaining the glucose level, IV?
I'm asking about the which medicine
or the steroids or
yeah.
cortisol steroid.
Yes, two words. Stick. Okay. Bye. Thank you.
Thank you so much.
Thank you, everyone. We are done with the presentation.
Devesh?
And Yes, sir.
I had 3-4 questions at the beginning of the session.
Yes, sir.
Now that question is open for all the 8 groups. I would like to know the answer from them. Call one by one.
Okay. So if you could also repeat the questions so that they can just.
Who was the first person to whom insulin was given? Now I have changed the question.
Yes, sir. Exactly. So anyone from group 1 to 8, anyone willing to answer? You can also type in the chat box.
Best in Banting.
What's your answer? Team 3?
Best in Banting. I mean, they found insulin and they injected it to themselves.
No. Okay.
Leonard Thompson.
Sir, it's Leonard Thompson.
It was Leonard Thompson.
Who had raised his hand first?
Yeah, I think
Team 5.
No,
Team 4.
you decide yourself. Which group? This I have already told, so I am not going to judge by this. So this is just for the sake of knowledge I have asked. How many persons were involved in the discovery of insulin?
4.
Name?
4 people.
Name.
Banting best.
Banting best, good. Banting best, good. Go ahead.
MacLeod, Collip.
James B.
Yeah. But leave it. MacLeod and Collip. Whoever had given this answer? Which group?
Team 5.
Team 5.
It was collectively 4 and 5. Yes.
There was that you have to decide which group had given the answer.
Yes, sir.
Okay. I have asked another question. Which molecule in the medicine had received maximum number of Nobel Prize?
Insulin.
How many Nobel Prize? And name the Nobel Prize winners. No. I mean, these are just I'm creating an interest with all of you.
Banting got Nobel Prize.
Yeah, Banting best. Someone told some name?
Banting and MacLeod got for discovery.
No. That another name. Someone I have heard from the subgroup. That was right answer.
MacLeod.
No, I totally agree. Banting, Best, MacLeod, Collip. Keep it apart. Now move to another. There are 3 more. There are.
So is it Sanger?
Yeah. For what?
F. Sanger. It's from Team 6.
Yeah. Which group?
Team
6, sir.
Team
5.
6.
The 5 also.
Oh, yeah, all
5
5,
also?
6.
5 and
Okay.
7.
Chalo, theek hai.
Okay,
Good,
5
good.
and 6. Okay.
I would like to create interest in you all. There are remaining 2.
Sir, one was in 1926 by Abel for crystallization of insulin.
क्या नाम है तुम्हारा? What is your name?
Abhijit.
Good.
Abhijit from Team 4.
That
Team 4. Okay,
your,
noted.
Team
4 noted,
one
sir.
left. One left.
Sanger and Hodgkin too.
ठीक है. You are right. Dorothy Hodgkins. Chalo, good.
Okay.
This will create your interest in medicine. And another question I have asked, the 75 gram of anhydrous glucose is equivalent to how much of the commonly prescribed glucose, which is available in market?
Glucose D 3/4 of the 100-gram pack.
No. Basically, what we use, I would like to.
416.
No. Just I am giving the information. What glucose
82.5.
The glucose which has been advised to use is anhydrous glucose. The glucose which is available in the market is a hydrous glucose. So you have to add 10%. So
82.5.
82.5%. That's all. Thank you. You
And
all.
yes, sir, thank you so much for your patience, sir. And also,
You keep,
we'll be,
you take out all the
yes,
participants from the conversation so that I can tell you the name of the, and you have to disclose the name.
okay. So we'll be taking a few minutes to announce to calculate the marks and the results. Meanwhile, we'll be putting up the feedback form. It would be very great if you just fill it. Any feedback related to any section of the event, whether it's this webinar, the quiz, the GD, the question answer session, anything. So we'll be dropping it in the Zoom chat, also in your respective groups as well. By the time sir can calculate the marks, and then we can move
No,
forward.
I have calculated the marks. You can
Okay, sir.
take them off so that I can communicate to you only, or your other other team members.
Okay, sir. We can do
It
that
would
after
not
we
look
have.
nice from me, na?
Okay, sir. After we have done announcing the winners, we can just tell them to leave the meeting, and then we can have it all. For sure, sir.
No, sir, you can announce the winners. If
Yes,
that's
Yeah, so you can definitely announce the winners right now. If you are up
No,
for
winner is group 8.
Congratulations.
Congratulations, Group 8, led by
Congratulations,
Ananya
Group 8.
Vadhera.
The second position is group 2.
Congratulations, Group 2.
Most of the groups had done well, but marks only not given to their presentation. How you present also. So the group, they had done fairly good in all the aspect, leaving few things apart. And the group 8 followed by group 2, and the rest of the group follows thereafter.
Okay, thank you, sir. Ananya, can you just name out your co-participants if you know them?
I can leave now, Devesh.
Yes, sir. Thank you so much for coming for the event, sir.
One thing I forgot to mention, one of your chat question was why to feel sleepy and dizzy. Actually, when you are having that much of glycosuria, you are likely to have dehydration. There may be some sort of electrolyte disturbance. So it causes weakness at the level of muscles and at the upper stair also. So not at the level of brain glucose is doing something, but you are likely to have dehydration. You are likely to have dyselectrolytemia. That will lead to you dizziness and sleepiness.
Okay. Thank you so much, sir.
Okay.
Really enlightened by your presence, and that's all for us. We'll be talking with the winners for now. Thank you so much. Okay. Who all were the part of Team 8? Can you have just a count of them?
So I know Savira and I don't know how to pronounce the other one. Srila, I think.
So how many of you were there in the breakout room, if you remember?
Srila and one
Yes.
audio wasn't working.
Devesh, all of them were there. I was the facilitator for the group. All
Okay.
6 participants were present.
Okay, that's great. If you could have their name, and so that we can proceed, we can give their name for the certificate of acknowledgement. That would be great. Also, congratulations, Team 2, led by Madhav Goyal. And thank you so much, guys, for coming for the event, enjoying it process by process, from webinar to quiz, and then finally reaching the GD discussions. I hope you like it, and any kind of feedback we are open to. If you want to share it right now, we are here. And also we have let out the form. Do fill it. Anything you want to say, anything regarding the event, because we might come up with events like these with a guest speaker from a prestigious college of India, and then with the same process, the webinar, the quiz, and the group discussion, we'll be coming up with more topics ahead. So we would sincerely like to know the feedback so that we can improve ourselves and move forward with it. Thank you so much.
We're really sorry, but we'll be giving the prizes the certificates to only the best group and not the second one. We're really sorry for that. Guys, anybody wants to come up and speak something? Like it's
Stage is all yours, man.
Yes, the stage is all yours. Okay, so like congratulations, team 8. And we shall end the meeting then, Devesh. Any other?
Yeah, we can end the meeting, and Madhav, I can have a talk to you later regarding the second prize. Okay. Thank you so much for coming, and we'll be ending the meeting in 20 seconds. Thank you so much.
And again, congratulations. Great job, guys.
Yeah.
We hope like everybody of you enjoyed in the group discussion.